Okay, we are now recording. Let me just open up these beautiful slides again. And I also wanted to really thank everyone who gave us so many questions during the registration process. We are going to do our very best to answer some of those questions during our talk. A lot of you had questions about implementation, so some of these questions are questions in progress, but we are going to do our best to answer everything that you asked. And again, please use the chat, raise your hand to engage in real time. And finally, I just want to promote our next webinar, which is coming up in November. And it's focused on another kind of PEP, HIV PEP, which is long neglected, something that we could really improve our efforts around. So we're going to have a great webinar focused on research programming and uptake of PEP, HIV PEP. And finally, our agenda for today. I am really excited about this amazing group of presenters we've pulled together. We have Dr. Connie Celum, Rodney Perkins, Dr. Jenell Stewart, Dr. Victor Omollo, and Jennifer Mahn. They'll each introduce themselves. I'm not going to go through bios. So they'll tell you who they are and tell you as much as they want you to know. And we will go ahead and get started. Let me stop sharing my screen. Okay, wonderful. Now, without further ado, I would love to ask Connie to kick us off with her presentation today. Connie Celum.
Hi, Jim. Are you going to be advancing my slides, or can I share my own screen?
It would be great if you shared them, but I would also share them for you if you would prefer
No, that's
that.
fine. That works great. Can you see it?
Yes, you're not in presentation mode yet, but
there we go.
Wonderful.
Well,
thank you, Connie. Go ahead.
Thank you. It's wonderful to see a lot of familiar names in the participant list, and thank you for the opportunity to present. I'm a professor of global health and medicine and epidemiology at the University of Washington, and one of the co-principal investigators for what we call the Doxy PEP study, which was recently highlighted at the AIDS 2022 meeting. And we looked at doxycycline as post-exposure prophylaxis for prevention of STIs among men who have sex with men and transgender women who are living with HIV or on PrEP. See if I can find that little button there. We received doxycycline from Mahn Pharmaceuticals and lab support from Cepheid and Hologic. So the rationale for this is that we had data for the last 6-7 years that show that in the United States that we're continuing to see increases in bacterial STIs, chlamydia, gonorrhea, and syphilis. And very alarmingly, in the last few years, are seeing increases in congenital syphilis, which is really tragic. And we've been using the same strategies to try to interrupt STIs in terms of education about it, diagnosis, and treatment, but clearly what we're doing is not enough. Men who have sex with men are disproportionately impacted by STIs, as shown in these curves and these graphs from the CDC in terms of gonorrhea, chlamydia, and syphilis compared to other populations. So the Doxy PEP study was built on some data that had been published a few years ago from the Ipergay study, in which they showed that they were able to reduce chlamydia and syphilis when taken after sex. We wanted to build on that because it was felt that wasn't enough data to guide policy to see whether or not Doxy PEP after sex would decrease the 3 most common bacterial STIs, gonorrhea, chlamydia, and early syphilis, and to understand the impact of intermittent doxy use on antibiotic resistance, both in STIs and other bacteria. So you might ask, well, why doxycycline? And it's because there's decades of experience with it in terms of its safety, that it's well tolerated and inexpensive, and it's active against chlamydia and syphilis. We knew from a lot of surveillance work from CDC and others that gonorrhea often has resistance, and it varies globally. And yet we're not sure. It may still be that Doxy would work against as prevention as opposed to treatment for gonorrhea with tetracycline resistance. So there's a lot of reasons why doxycycline made sense to study for this indication. What we did is to do an open label study of doxycycline 200 milligrams taken as PEP within 72 hours after condomless sex. And we counseled people to take no more than 200 milligrams every 24 hours. We did this study in two cohorts, one a cohort of MSM and transgender women living with HIV, and we plan to enroll 390, and then a similar size cohort among MSM and transgender women who are on PrEP, HIV PrEP. And the study was designed to randomize 2-to-1. So there was a 2/3 chance they would get randomized to Doxy PEP and a 1/3 chance to no PEP. And STI testing occurred quarterly. We enrolled men who were male sex at birth, and as I said, living with HIV or on PrEP, had one or more STIs in the past 12 months, and condomless sex with at least one male partner in the past 12 months. This study was done in 2 HIV clinics in San Francisco and Seattle, and 2 sexual health clinics in San Francisco and Seattle. This is the way we messaged how to take it up to 72 hours after sex. If people had sex daily, to take no more than 1 dose per day, and tried to encourage people to take it with water, to counsel about photosensitivity and possibility for GI side effects. Our primary endpoint was having at least one incident STI, gonorrhea, chlamydia, or syphilis, during a follow-up quarter. All our STI endpoints were adjudicated by a blinded endpoint committee, and we designed the study with 80% power to detect a 50% decrease, assuming that we would have a quarterly STI rate of 10% in the standard of care arm. We powered it separately for the 2 cohorts. We had an independent data safety monitoring board that was monitoring the study, and they were guided by a stopping rule that only if both cohorts crossed a pre-specified efficacy boundary should we stop. And on May 13th of this year, at the single scheduled interim efficacy analysis, the Data Safety Monitoring Board recommended stopping enrollment due to crossing those effectiveness boundaries. So I'm showing you the data from the 501 participants that were enrolled and had at least some 1/4 of follow-up by the time of the Dsmb meeting, and you can see their characteristics. Median age was 38, with a slightly older age in the cohort living with HIV. About 2/3 were white, and then about almost 10% were Black. About 30% were Hispanic or Latinx, and most identified their gender as male. We had about 13% who had both men and women partners. And you can see here that about the median number of partners was 9 in the past 3 months, and a fair amount of substance use in the past 3 months, particularly stimulants and poppers and club drugs. So getting to the primary result, we found a reduction of almost 2/3 in both cohorts, and I'm showing you here the data side by side for the 2 cohorts. In blue is gonorrhea, incident gonorrhea cases, orange chlamydia, green is syphilis, and in Black at the bottom is having more than 1 STI per quarter. You can see that it was a very big reduction, and you can see that we saw it for all the STIs, but that's easier to see on this slide where we also break it down by anatomic site. We had mainly rectal and pharyngeal gonorrhea and chlamydia, not much urethral in the top height bars. You can see that the distinctions, the separations by pathogen, that we saw about a 56% reduction in gonorrhea, over about 80% between the two cohorts for chlamydia and about 80% for syphilis. So very significant reductions. And this is on a per quarter basis. We looked at sexual behavior and at enrollment, about, as I said, there's a median of 9 sex partners with a fairly wide distribution, 5 sex acts per month, and 90% of sex was reported as condomless. We looked for evidence of risk compensation and found no significant change in number of partners, number of sex acts within the DoxyPEP arm or between the DoxyPEP and standard of care arm. Adherence is challenging to measure in a precise way in an event-driven kind of study, but based on self-report, 86% reported DoxyPEP always or often after anal or vaginal sex. And our best estimate about how much they took is that based on the self-report data that they took about 4 doses per month. But just again, look at the distribution and you can see that about a quarter had 10 doses, reported 10 doses per month or more based on our quarterly interviews. We found that DoxyPEP was safe, tolerable, and highly acceptable in terms of our self-reported adverse events, as well as looking at CBCs and liver enzymes. It was highly tolerable and highly acceptable. In terms of antimicrobial resistance, the data are, this is obviously an area of great interest. In terms of gonorrhea, we had those that had a positive nucleic acid test. We tried to get in for a culture through the CDC surge protocol. And we have data for about 17% of endpoints. It's sometimes hard to get people in before they were treated, and not all of the samples that were taken grew. But for the samples we have, I'm showing it on the right, that you can see that there was about 25% had resistance at baseline, a slight shift in the DoxyPEP arm among those who had gonorrhea during follow-up, but the numbers are really small. Our prevalence of gonorrhea with tetracycline resistant is really consistent with the CDC surge data nationally. Just to put this in perspective in terms of the IPRGay study, where they did not see an impact on gonorrhea in their DoxyPEP study, they had much higher resistance at the time that study was done. So that may be a factor. So just to wrap up, what do we know? We know in our study and also in the IPRGay study that DoxyPEP works very well to prevent STIs in this population with over a 60% reduction per quarter. And we saw a reduction in each of these 3 bacterial STIs per quarter, including gonorrhea. In terms of number needed to treat to prevent a quarter with an STI, we found you would need to treat about 5 people. And this is in the context of a population with a very high STI incidence, 30% per quarter in the control arm. It was safe and well tolerated. What we don't know yet, but you'll hear more from a couple of our colleagues about the Kenya study, is the efficacy and the risk-benefit ratio in cisgender women or in men who have sex with women. Where we are looking at bystander bacteria, so to speak, Staph aureus, and on the gut microbiome, but we don't have those data to share yet. And we're also looking, but it's harder than you think, to look at doxycycline susceptibility for chlamydia. I've shown you the data for gonorrhea. We need more data on gonorrhea as well, and then syphilis and Mycoplasma genitalium. So many of the questions submitted had to do with implementation. That's under discussion, and CDC will be holding a consultation and issuing interim guidance. So currently they don't, their treatment guidelines for STIs do not include a recommendation for or against DoxyPEP. They're working on guidance. Some clinicians are prescribing, mostly on a case-by-case basis, and our impression is that the community interest is high. So next steps, and this is my last slide, the control arm has been offered DoxyPEP. Most have taken it up. We're following participants through next May, and we'll have additional data on incident STIs, antimicrobial resistance, and sexual behavior after initiating DoxyPEP. We're looking at antibiotic resistance in Staph aureus, commensal Neisseria, the gut microbiome, and there's several other studies underway that will have data over some sooner than others, but I keep paying attention to this space because I think we'll be relying on all these studies to shed light on this new intervention. And as I mentioned, we're having stakeholder discussions. There will be normative guidance by CDC, as well as we hope from WHO, and have started those conversations. And then just the last point is that you can only learn so much in one single study. And I think that if this is adopted for wide-scale implementation, we'll need to embed some monitoring studies to understand the impact on DoxyPEP use on antimicrobial resistance, including in GC. And I just want to thank an amazing team, including my co-PI, Annie Luchtmeyer, our colleagues in San Francisco and Seattle, and our funding from the NIH DMID. So thank you.
Thank you so much, Connie, as ever, a tour de force, and what interesting information around DoxyPEP for gay and bisexual men and transgender women. We do have a few questions. One is, let me just make sure I scroll back up here. Were there any differences in the LGV strain of chlamydia?
We do testing for LGV. We just did the regular, basically nucleic acid amplification for chlamydia. So we don't have those data.
Great, thank you. And can you just remind us, what's the dosing? How does the dosing work for DoxyPEP?
We told them to take 200 milligrams of doxycycline hyclate, but there are different formulations, but 200 milligrams of doxycycline within 72 hours. We encourage people to try to take it earlier if they could, like within 24 hours, but we said really up to 72 hours after condomless sex.
Great, thank you. Jean, I'm going to ask you to, if you would mind, ask your question live on camera. And while you're getting ready, I'm going to ask another question from the chat. Connie, can you say a bit more about any risk involving developments of antibiotic resistant strains of STIs from using DoxyPEP?
Well, I think we don't expect to induce resistance in either chlamydia or syphilis. We've used, Doxy is currently the CDC's recommendation for treatment of chlamydia and has been used for decades. And there's been no evidence to date that chlamydia or syphilis has become resistant to it. Since typically we don't culture chlamydia anymore, we just look at nucleic acid amplification. It's harder to really measure resistance directly. We're working on that, but so far we didn't enter this study, and I think people are generally not expecting that that's a big risk. Gonorrhea, we know, is already often resistant. I showed you the data from the CDC that shows that nationally about a quarter of gonorrhea has tetracycline resistance, and Doxy and tetracycline class is not used for treatment. So we knew that, that's really not a big risk, but it's still there's concern in general with gonorrhea that we only right now we're relying on cephalosporins, ceftriaxone to treat it. So there's still interest in whether or not gonorrhea becomes more resistant.
Great, and we're going to take our last question, and we're going to take that live from our colleague, Jean.
Hi, everybody. Can you see me okay?
Yes.
Okay, great. I can't see myself, so no problem. I just was wondering, that language was intriguing, but I didn't fully grasp it, where you had a slide talking about needing to treat 5 people in order to have a certain kind of impact. But there was just some language there that I didn't fully grasp about quarters, or anyway, I just thought I'd pose the question.
Yeah, well, our endpoint was measured per quarter. Did someone get an STI per quarter? And so what we quantified is how many people would you have to treat in a given quarter to prevent someone having an STI, and that would be 5 to prevent one person getting an STI. And it's a way that we often talk about interventions to try to get a sense of, how many people do you have to treat with statins to prevent a stroke or heart attack. And in this situation, that's 5 is actually a pretty low number for prevention interventions. When we did our HIV PrEP studies, it was more like you would have to treat, depending on your eligibility criteria, 10 or 13 to prevent one HIV infection. So it's really saying, if you gave it to a Doxy-PEP in a population with this high a risk of getting an STI, and remember, it was 30% in the standard of care arm, that's a really high risk of getting an STI on it within a 3-month period, that you would need to treat 5 people to prevent one getting an STI.
Understood. Thank you.
Thanks for the question, Jean. Thank you, Connie. I'm going to invite you to stop sharing your screen. And I'm going to just quickly preview what we have coming next. We're going to be hearing from Rodney Perkins, who's also on the West Coast, waking up very early with us today, to talk about community perspectives and reactions to the Doxy-PEP study. And then we're going to have a tag team presentation from Jenell and Victor, who are going to be talking about Doxy-PEP with cisgender women in Kenya, a study that's ongoing. And then we're going to wind up with some great perspectives from Jennifer with the National Coalition of STD Directors here in the United States. And I just want to kind of remind folks that this is not being implemented yet. So this is pre-implementation. We're still, the science is still rolling in, and folks like WHO and CDC are still considering. So it is not yet an approved, quote, or recommended, quote unquote, intervention. This is, these things are in the works. So with that said, I am going to ask Rodney to introduce himself and share his screen and share with us some of the community perspectives around Doxy-PEP. Thanks, Rodney. And Rodney, if you wouldn't mind being on video, we'd love to see you. There you go. Thank you. And it's all yours, my friends.
I'm just trying to navigate here. All right. Thank you very much for the invitation to share this work. My name is Rodney Perkins. I am a doctoral candidate here at the University of Washington. Prior to coming to the University of Washington, I'm from the East Coast. I used to be the director of the Gay Men's Health and Wellness Clinic in Washington, DC. And so with that, we'll get started. I have no disclosures to discuss. And so basically, what I'm going to share with you is that as a complement to the clinical trial, we are doing a qualitative study, really trying to get an idea of kind of like the experiences amongst the participants that have been in both arms of the study. And so within the main study, this is basically some of the research questions that we're looking at, which is really the attitudes around DoxyPEP and the clinical trial, really looking at their sexual and STI prevention history and sort of attitudes around STIs, attitudes around ARTs and PrEP, and really looking at HIV disclosure. Some of the experiences taking DoxyPEP, including adherence, side effects, sexual behavior, beliefs about DoxyPEP efficacy and when it's needed, any concerns that they may have, as well as partner and peer attitudes about DoxyPEP. And within the study is a sub-study that's being done, which is actually my dissertation work, which is basically looking at the relationship between DoxyPEP use and sexual satisfaction and the meaning of sexual pleasure and intimacy. And then with those two, trying to take on kind of what are some of the positive sexuality components around DoxyPEP. And then the third component would be looking at healthcare providers and their perspectives and their willingness to prescribe. And so to give you a little bit of an idea of, so what I basically did is I chose to basically use the questions that were submitted to kind of respond to. So the first question was really about motivations for DoxyPEP, for the DoxyPEP study. And so basically, the interest to be a part of the study was mainly around reducing STI incidence. Most people perceive their STI risk kind of very high for the most part. But ideally, they were looking to more to protect themselves and others. So it had sort of this kind of altruism kind of going on in the study. The other question was a lot of community education needed, or were the participants already aware of DoxyPEP? As far as the study is concerned, we really only went over the side effects in the consent piece. We gave a little bit of background about Doxy in the consent. And then those who were randomized to take Doxy were given sort of some guidelines on how to take it within that 72 hours. Over time, I think participants had heard about it, heard about different studies that were being done. So some people came with that knowledge. But then over time, as it's kind of like the study got going, people started to hear it from it in the community. So over time, I think people learned a bit more. However, there was some confusion regarding DoxyPEP when it was needed, kind of the timing. When should you take it, whether it was oral sex or kissing. So there were some questions about whether it should be taken during those particular times. What were some of the concerns participants had regarding regarding the study? Basically, I think they were common as what most people were asking, which is basically, antibiotic resistance. People thought some, unforeseen exposure to taking the medication, concerns around the long-term effects. And what I believe is that the people who had concerns in this nature pretty much monitored how much Doxy they took in. So there was definitely some people who took it more frequently than others, but I think those who pretty much had a concern sort of monitored or tapered the way that they took the medication. As far as pushbacks, I don't think there were any pushbacks. I know initially there was a bit of a awkwardness because to be eligible, you had to have had a positive STI within the last 12 months. And so some people who didn't qualify based on that criteria kind of like, oh, I think I need to go out and get an STI so that I could participate. So that was one of the only kind of pushback that really came about. But those people who, eventually down the line, they did come back to want to be a part of the study. But for the most part, it was uniformly positive. People were quite excited about the study. With regards to any sex shaming, or as we've had with HIV, PrEP, or monkeypox, for the most part, I would say I think we're on the way. I would put it that way, because basically partner and peer attitudes were positive. No one really had any issues with regards to like the partners that they shared that they were taking it with. However, DoxyPEP is trending on hookup sites and profiles And that actually helped spark communication as well as interest, because what we recognize is that once people started to put on their profile that they were on DoxyPEP, we noticed that we started to get more calls and people were calling in to wanting to be a part of the study. And like I said, interest sort of grew. However, in some social media chat rooms, there is some discussion around popping Doxy and just, having carefree sex and just popping a Doxy afterwards. There's some articles on, Doxy holidays, where people go away, they take Doxy, and they have all the success they want. So we do have some of that shaming piece kind of filtering in. With regards to the community interest and community demand for Doxy, I think the big question, are people having more sex? Yes. Are they having more partners? Yes. The types of sex is also impacted. So that's definitely occurring. However, what I think is great is that it has really reduced the anxiety over STI transmission. I think this is really significant for those individuals living with HIV, that it kind of creates that less stress, less anxiety. For some, it increased communication with partners, talking more about their sexual needs, boundaries, and STI prevention. In the pre-trial, STI transmission was broadly addressed by test and treat rather than with condoms. And so we recognize that people are using condoms less. One thing I recognize is some of the participants were testing more frequently. So although they were on PrEP and getting tested every 3 months, there were participants who tested every month. They actually went to have a throat and rectal swab done in between their PrEP visits to make sure they weren't contracting an STI. And being a part of the study allowed them to relax that particular practice, because now they were quite comfortable that they weren't being exposed to any STIs. With regards to, well, this is just a continuation. So others was that it was well tolerated and he perceived to be highly effective amongst participants. It was easy to adhere to. A lot of people kept a bottle within their gym bag. They kept a bottle at home. Some people kept a bottle, at their work, so that depending on where they were, they had a bottle to basically be able to take a dose of the medication. Nearly all participants reported interest in continuing. And I'm interested to say nearly all is because there are some people didn't think that they were that sexually active to continue on, but for the most part, most of the participants wanted to continue, and they felt comfortable having that conversation with their provider to continue as well. With regards to acceptance in the medical community and insurance coverage, I think the providers, as I said, part of my dissertation was really talking to some of the providers as well. And some of the conversations I've had with them, the concerns are quite similar to what most of you all have kind of presented as your questions for the webinar. Antibiotic resistance is a hot topic, and then inappropriate or inadequate treatment of syphilis was another. But I've kind of put them into a category of being conservatively optimistic. So I think they're really excited about this, but they still have some other questions, which I think more data would be able to help with that, as well as guidance from the CDC. However, there are some providers with patients on DoxyPEP. I think the patient's profile or the profiles that are using it currently were patients who've had multiple chlamydial infections, and then patients with multiple partners who are known to the provider, and the provider felt comfortable prescribing it for that particular one. So definitely have patients who are out there currently taking it. And then I wasn't really able to confirm with regards to coverage. Some of the participants in the study who are currently using it have not presented an issue with insurance. However, I've gotten a couple of calls with questions with regards to coverage and paying out of pocket. And I know one person's insurance rejected it because there was no justification based on what he was explaining to me. However, he paid for it out of pocket and he figured he would get reimbursed, but it didn't come back to be a problem. So I'm assuming his out-of-pocket expense wasn't that dramatic. And for the last point, I just put a plug in for my study. I am looking for healthcare providers. So any providers out there are willing to sit down and chat with me via Zoom. I'm open to meeting with you. We're looking for physicians, nurse practitioners, physician assistants, and pharmacists to talk about their thoughts and perspectives on the use of Doxy in this particular format. And there is a financial compensation. And if you ever inclined, please feel free to reach out to me. This is my information here. Yeah, and I'm sure you can follow up with Jim if you aren't able to capture it now. And as Connie said, to thank our wonderful team of participants who are working along with us to bring you this information.
Thank you so much, Rodney. That was beautiful, really interesting. I know I have a few questions, but I'm going to start with a question from the chat. I'm going to also remind folks that they can raise their hand if they want to ask a question on camera. We love that. So this is a question that came in the chat, and it says, Connie outlined the dosing, which is 200 milligrams within 72 hours. Did your study find any confusion regarding appropriate dosing and timing? And how would you recommend messaging to be addressed, whether when it's approved or as people start using it informally? Like, so it's about, was there confusion about dosing? And then what are your recommendations around how we message so to make sure that that's clear?
Yeah, I think there is some components around, there was some studies that was done with PrEP, STI PrEP. So there's some information out there regarding that. And I think some of the participants who read kind of confused that after they were enrolled. The 200 milligram is pretty standard because that's what's issued to the patient. So they get a 200 milligram, they got a 90-day supply at each visit, and we top them up if they basically ran out of pills. So I think the issue around messaging is within the 72 hours. And I think it's important to communicate within the 72 hours. However, I think the backup to that is that if a person, and the way I communicate is if you were going away for the weekend, if Friday you didn't take your pills, when you come back on Sunday, you take one pill. However, you want to take the pill as closest to your last sexual encounter. So it's really on demand for you to plan. Most people know I'm going to have sex Friday and Saturday, and that'll be it. And then they take a pill on Friday. So it's really about taking it at the last time you think you're going to have sex, but within that 72 hours. And I think that pretty much solidified it for most people.
So this is an interesting question from Miguel. Did participants take the full 200 milligrams of Doxy in one take, or did they spread it out throughout the day to avoid side effects?
They took it it's a 1 milligram, it's a big pill. So it's a 200 milligram tablet that they would take. And there was no breaking it up or spraying it out because it was just one pill.
Great, thank you. So I have a couple of things on my mind, and I love that you talk about, people talking about having more pleasure, having more sex. And, in our field for a long time, this idea of gay men, especially having more sex, just makes everyone clutch their pearls and freak out like, oh my God, they're going to have more sex. Oh my God, they're going to enjoy it. Like, we don't want that. So, in this study, the folks who came in were obviously on the leading edge and maybe different than lots of folks around the country and communities when we start to roll this out. So what are your recommendations around how we talk about this and how we, de-shame sex, de-shame quantity of sex, de-shame pleasure, and allow people to kind of have the sex lives they want and use the kind of healthcare they desire?
Yeah. So that's kind of the spin that I'm putting on for my research, right? Because I believe when I think about this, I think of men, when I think of individuals living with HIV, have carried the stigma and shame about a lot of things around transmission. And so I think it's really important to really bring pleasure into the discussion with that health visit, right? Is that, bringing in that 6P about pleasure and you're enjoying sex and bringing that component in, how can we help support that? I think that's really where we are in this. I think prevention is important. I think if the person is been exposed to STIs, then this becomes a good intervention. And what I like to think of it as is that, the joy of individuals who don't like to use protection, that we had these conversations that there are alternatives. There are safer sex. I think if I didn't bring it up in the picture that was on the slide where it talks about, you know, risky sex, we put these risks and components. With the new innovations, we should be talking about safer sex and the different ways of having safer sex, as opposed to you're at risk because of X, Y, and Z. So persons on PrEP have already taken a step in trying to prevent, you know, their exposure to HIV. The portion about using condoms now becomes, is that still necessary in the pleasure the person seeks in their sexual experience? So I think all these components has to be kind of brought into that visit to really figure out where is this, what is this person trying to find, right? Because telling them to wear condoms may not necessarily work. But what I loved about these participants who are on PrEP, they're already doing things to make themselves safer. They're on PrEP and they're testing more frequently to reduce that opportunity of having an infection on board. So we have to create the opportunities for people to have the sexual lives that they want and don't shame them for it. Yes, we're trying to prevent infections, right? But we also want a person to have a healthy sex life.
Yeah, thank you for that. It just reminds me of, you know, the definition that WHO uses for sexual health does not defer to disease prevention or disease management. And it really centers pleasure and wellness. And I think we would all do well to sort of banish the RISK word from our vocabulary, and you know, and really look at ourselves and say, why is it some people get to have sex and other people have risk factors? You know, some people engage in risk factors, some people engage in sex, and it's very interesting, like how that falls, like who we assign risk to and who we assign just having sex to. It's very rare when, you know, I've never told a girlfriend who is pregnant to say, oh my God, you have risk factors. What were you doing? You were engaging in risky sex. It's more like, yay, you're having a baby. So it's just, you know, it's an interesting, you know, there's some interesting discriminatory stuff that comes out there.
I think the big one for me is that people who, this is the way they've had sex all their life, and this is how they've always been taught to. And that in itself carries a level of stigma and burden that you see yourself based on how people speak to you.
Yeah, I think, you know, we a lot of the shaming and the finger wagging often comes from within communities. So certainly saw that when PrEP was rolled out. Some of the biggest anti-PrEP folks were other gay men. And I'm just wondering if we might see any of that as we start to roll out STI PEP. Do you foresee, you know, cadres of finger waggers or lots of people very concerned about resistance and not understanding resistance and kind of blowing that out of proportion?
I think the people who are concerned about resistance, as I said, I think participants who were concerned about resistance monitored how they took it, right? They basically wasn't trying to take a pill every day or even within the time frame. They pretty much only took the pill with their sexual encounters. And you could also tell because they also came back with the most medication, right? So the people who wasn't so much concerned about, you know, resistance basically took the pill more frequently. I think with regards to the shaming piece, I think the messaging around PrEP kind of had a certain eligibility criteria that kind of came along with it. And once that dissipated out into the community, people started to use it, right? And there's another component around monkeypox. It's the same thing, right? Monkeypox, once they heard that who was getting monkeypox, then that kind of like spilt out into the community, and the community started to weaponize it against one another, right? Oh, you're getting a monkeypox vaccine, that means you're out there having sex like that. And so I think how we message the intervention is really critical because it does spill out into the community, then it becomes a weapon within the community of how we talk to one another.
Very good. Thank you for that. We're going to move on. I'm going to invite you, Rodney. There's a couple questions in the chat that you may be able to help shed light on, but I just want to call out just verbally this notion of risk compensation, and there's, you know, in some of our research, we're still talking about risk compensation, and you know, frankly, that's kind of a problematic paradigm because it assumes that condoms are the gold standard.
Mm-hmm.
And condoms were the gold standard for a short period of time, or a of time during this crisis. Now we know that there's many options. So when we talk about risk compensating, it seems like we're prioritizing condoms compared to PrEP, compared to PAP, compared to U equals U. So anything really quick about risk compensation before I bring on our next two speakers?
I hate that concept. I unfortunately, is that all of a sudden, because it's drug, you're gonna start doing, having more sex. If that is what you desire, then what is wrong with that? If you're doing the things to keep yourself safe, you're taking the pill as you've created this pill for me to use for this purpose. Now that I am taking it and I'm doing the things that you've created for me, why are you concerned that I am enjoying sex or having more sex? And I think we always go to the person who's having more sex. What about the individual who just likes the fact that they are no longer anxious about the fact that they could get an STI, but yet they're having sex with one person? I mean, most people feel like that is true, but there are still people who have STIs who are married and birthing babies and doing other things, right? Everyone's at risk to have these things, but just because you have more sex, it seems to mean more. That's what you want to talk about. But there are people who were taking Doxy who I think had 2 or 3 partners, and I think don't get talked about because they didn't take a lot of pills. But the people who took a lot of pills, we talk about because they had a lot of sex.
Yeah, it's so interesting. And I'll just wrap up this part by saying, I think it's also really how we demonize STIs. I mean, if you are sexually active as a human, you are going to get some kind of STI. Like you are going to be exposed at some point or your life to something. Most of us have been exposed to HPV. And we have all of this shame and angst around it, but we don't have the same thing around getting a cold or catching the flu. But oh my God, you get an STI and you're some kind of monster. Never mind that an STI is an extremely normal thing to get. If you're a sexually active human being over your life, you are likely to bump into one. And it's not a big deal. It should not be treated as if it's this moral failure. But again, it's about sex. And certainly in the US culture, we're founded on Puritanism and lots of hypocrisy. And so anything sexually related is terrible. Anything else is, oh, it's just normal. People get a cold. You run into people, you get a cold once in a while.
Yeah.
So thank you very much, Rodney, for really getting my juices flowing. I love hearing about community impacts. And again, thank you, Connie, for the great setup. I'm going to now invite our next 2 speakers, Jenell and Victor, who are going to tag team today. I believe I'm sharing your slides. Is that right? Yes.
Yeah, if that's okay with you, Jim. Otherwise, I can.
It sure is. Yeah, I'm just confirming and finding them, and here they are. Let me get you to. So just go ahead and let me know when you want me to advance them, and you can please go ahead, introduce yourselves, and walk us through your talk.
Thank you so much. So I'm going to give this talk. I'll put my video off for the sake of the stability of my internet. Thank you so much for giving us this opportunity to contribute to this discussion by presenting our work on doxycycline for STI prevention for cisgender women in Kenya. I am Dr. Victor Omollo. I work with Kenya Medical Research Institute, and I'll co-present with my colleague, Dr. Jenell Stewart. I will move next slide. So let me start by acknowledging and thanking the participants in the dPEP Kenya trial, as well as the study staff at our Lumumba Clinic in Kisumu, Kenya. I also want to acknowledge the investigators and the funding that we got from the United States National Institute of Health. Next. let's start our talk by looking at this map that highlights the distribution of new sexually transmitted infections as estimated by World Health Organization in 2020. From here, we can see the highest number of infection is estimated in the WHO African region. Next slide. The increasing number of STIs is coming at a time when HIV oral pre-exposure prophylaxis is being incorporated into national guidelines and being scaled up to key and priority population, like the adolescents and young people between 15 to 24 years, who, for example, in Kenya, contributed to 42% of new HIV infections in 2021. Next slide. So ideally PrEP was not expected to prevent other sexually transmitted infection, but right now it is emerging into this global context with unprecedented rates of curable STIs. We are seeing higher rates being observed among young African women, and these rates are equally similar to the rates that we are seeing among men who are having sex with men, who have been given a lot of attention when we compare to the attention that is currently being given among young women in this setting. Next slide. So prior to the initiation of the Doxycycline PEP study in Kenya, there was evidence from studies among men who have sex with men that doxycycline can prevent sexually transmitted infection when taken after sexual exposure. And Professor Connie has talked about this. We have a number of ongoing studies in the United States of America, in France, and also in Australia that are trying to look at more evidence on the use of doxycycline for post-exposure prophylaxis against sexually transmitted infection. Next slide. But there's only one study highlighted in red here that is being conducted in Kenya, and it's the only study that is looking to provide evidence on doxycycline prophylaxis among cisgender women. Next slide. So doxycycline post-exposure prophylaxis is going to be impactful for African women. First, because sexually transmitted infection is highly prevalent in this setting, and the consequences of untreated sexually transmitted infection are arguably substantially greater among heterosexual women when you compare to men who have sex with men. Second, the current standard of care for STI management in this setting is symptomatic, which has the risk of missing a lot of infection that do not present with symptoms. And therefore, dPEP has the potential to treat any STI that can be potentially missed by asymptomatic management. Third, doxycycline is widely available in the African setting. It is affordable, and therefore women can easily pay out of their pocket to acquire it. And finally, doxycycline post-exposure prophylaxis provides this prevention intervention that women can control on their own without having to seek or get consent from another person to use it. Next slide.
Thank you so much, Dr. Omollo. Thank you for introducing the importance of providing dPEP for cisgender women. Really excited to be working on this study with you and this amazing team. The dPEP Kenya study team has been working on this since 2019. We launched in 2020, in February of 2020, and it is still ongoing. So I don't have results for you today, but I'm excited to tell you a little bit more about the study. Next slide. So similar to the DoxyPEP study that you just heard about from Connie, this is an open label trial providing 200 milligrams of doxycycline taken within 72 hours after sex, up to 1 time a day. Just as you saw with Connie's trial. Ours, however, was just a 1-to-1 randomization. We did not include people who were living with HIV. We only included cisgender women who were taking HIV PrEP, ages 18 to 30, so a slightly younger cohort than the DoxyPEP trial. We set out to enroll 446 people. Everyone in this trial will be followed for 1 year and tested quarterly for STIs. Next slide. So there are several aims for this trial I'd like to tell you about. The primary aim, similar to DoxyPEP, is to look at the efficacy. Can taking doxycycline after a sexual exposure prevent an incident STI? And this is a combined endpoint of gonorrhea, chlamydia, and syphilis. And in addition to that, we are looking at additional aims of safety, acceptability, adherence, and resistance. And I'll tell you a little bit more about some of those methods on the next slide, but I'll also call out that we're doing a cost effectiveness study as well as we start to think about potential implementation in low and middle income countries. Next slide. Okay, a few key methods to tell you about. So for the STI testing, keeping in mind that in this setting currently, as Dr. Omollo just mentioned, it's syndromic management that guides STI prevention and care. So only if you present with a symptom of an STI, which is only about 30% of the time, do people get any treatment for STIs, and that treatment that they get is broad across all common STIs, not targeted to the one that they're presenting with. However, in this trial, we did provide etiologic STI testing using an expert machine for same-day results. And this is for everyone in the trial in the standard of care arm as well as the dPEP arm. In addition to that, we did confirmatory testing following treatment to ensure that all infections cleared. So everyone came back in about 2 to 4 weeks after treatment to ensure that their infection had cleared. And similar to the DoxyPEP trial, although this is an open label trial, we do have a blinded endpoint adjudication committee for the determination of each new STI. Resistance, a very hot topic here. You can stay on that last slide. Thanks, Jim. Resistance is a very hot topic, and we're using molecular testing to look for the TETM gene in gonorrhea and measuring that prevalence across the study. As Connie mentioned, resistance in chlamydia has not yet been described, but we're monitoring for it anyway with the TETC gene to see if there's any evidence of this over the course of the trial. Additionally, there's many analyses that will happen in this trial, but a few that I'd like to highlight here today based on some of the questions that I saw. We'll be looking at adherence effectiveness analysis using hair samples to look at the amount of drug that people were exposed to in the last month, to look at the impact of high usage versus low usage in this group. And we'll also be looking for any potential impact of DoxyPEP on trichomonas infections, as well as Mycoplasma genitalium. And we'll also be looking at some of the impacts on the vaginal microbiome over the course of the study. Next slide. Okay, so as I mentioned, I don't have results for you today as the study is still ongoing, but I can tell you a little bit about who enrolled in this trial. So we enrolled from February of 2020 until November of 2021, and we enrolled 449 cisgender women taking HIV PrEP. This is a fairly young cohort of a median age of 24, with more than 60% under the age of 25. Most people had never been married, and most people had had a child prior to enrollment, with about 70% having delivered one child or more. And we had 57% taking a long-acting reversible contraception, with around 38% not using any contraception. We did not require contraception for enrollment in this trial. Condom use with the last intercourse at the time of enrollment was low at around 32%. Indicative of the need for another form of STI prevention, because clearly condoms were not working for this population. We asked about transactional sex in the last 3 months, and 37% of our participants had engaged in some form of transactional sex in the last 3 months. At enrollment, we had a combined prevalence of 17.9% of chlamydia, gonorrhea, and syphilis, with syphilis rates being incredibly low, true to this region, only 2 cases of syphilis at enrollment. So primarily driven by chlamydia as well as some gonorrhea at enrollment. Next slide. So while we wait for the results of this trial, we're also thinking about next steps and the various challenges and opportunities when it comes to thinking about dPEP for cisgender women. Challenges, as Rodney just very clearly outlined, is sexual health stigma. We need to make sure that even if this works, that people have access in a safe and comfortable way and they're not stigmatized for accessing preventive treatment, or sorry, prevention. And then the complicating thing with women is that we haven't seen data for pregnancy. There's no evidence that Doxy is harmful in pregnancy, and we've certainly seen cases where pregnant people are given Doxycycline for life-saving treatment, and there's been no observed birth defects, but it hasn't been exclusively studied, so it can't be excluded. I will call out that there used to be a guidance not to give Doxycycline to young children because of the concern for discoloration of teeth. And the United States Pediatric Society has changed the ruling on that. And so Doxycycline can now safely be given to children. And that was due to prior knowledge of a related medication, Tetracycline. So as we see more about Doxycycline, we may see that it is increasingly safe. Additionally, a challenge is surrounding STI testing. This study uses STI testing to guide implementation within the research environment, but many low and middle income countries, the majority of the world, does not have access to STI testing at present. And this goes hand in hand with how do we think about implementing this outside of research settings. A few important opportunities I'd like to call out as more and more countries and counties are thinking about how to increase access for PrEP, HIV PrEP for cisgender women. This is an excellent opportunity to think about how we're going to integrate STI prevention at the same time. Maybe that could be dPEP. And then, thinking about the impacts of STIs on a uterus and the potential for long-term complications with fertility issues, more and more women are thinking about how to preserve their fertility, how to protect the health of their uterus. And so thinking about additional preventive tools like dPEP for preventing STIs before they can cause any scarring. And as Connie pointed out, within the United States, we're seeing skyrocketing rates of congenital syphilis. And so clearly there is a need for STI prevention among cisgender women. And then, as we've heard from a number of people today, Doxycycline is cheap. And so I think that this could provide a clear and faster path to implementation. All right, I will end there and thank everyone for your interest in this topic. And again, thanking the dPEP team, which is a collaboration between Kenya Medical Research Institute and the University of Washington. Thank you.
Thank you so much, Jenell, and thank you so much, Victor. Let me stop sharing your slides here. And let's see if we have time for a question. I'd love to have a question live. So is someone like to raise their hand and go on camera and ask a question live? Of course, I have question. Oh, we have one. Thank you, Paul. Go ahead.
Yes, I wanted to follow up on the question about doxycycline in pregnancy. Is there anything in the informed consent that at least advises of that possibility of safety concerns?
Yeah, thank you so much for that question. So during the trial, anyone who became pregnant, we stopped Doxycycline because of the lack of evidence to guide safety. So in an abundance of caution, we had participants who became pregnant during the trial stop their Doxycycline during their pregnancy and then restart, keeping in mind that this is guided primarily by evidence from Tetracycline, which showed a third trimester potential for birth defects. And so we had no concerns about people being on dPEP in the first trimester until they came into their quarterly visit and discussed with us a new pregnancy.
So is this going to limit the utility of this intervention when the final results come out?
Yeah, I think this is a challenge for thinking about many interventions for cisgender women. When we don't have trials that enroll pregnant people, it limits the impact of implementation. And so I'd say with the current evidence, there are limitations on use for cisgender women, but my hope is that more evidence will become available to broaden the safety profile of doxycycline.
Great. I'm going to do two quick follow-up questions. If you can answer them briefly, Jenell or Victor. Is there any interim analysis planned by the DSMB for your study?
Thank you for that question. We have had a DSMB following along. We are going to see this trial through to close. And so our last participant enrolled in November of 2021. So if you do the math, we are within a month of our last study visit. So we will have a full data set available.
Great, thank you. And the last one from the chat, and then we're going to move on to Jennifer from the National Coalition of STD Directors. Paul says, great work. Thank you for sharing. Curious as to what the estimated prevalence of tetracycline resistance is in Nigeria, Kenya, or the area. What do we know about tetracycline resistance?
I'm happy to chime in on some preliminary data, and I'd also like to hear from Dr. Omollo if you have additional knowledge on this. When we did look at some samples collected in the Partners PrEP trial that was done in Kenya and Uganda, we saw very high rates of tetracycline-resistant gonorrhea at baseline, upwards of 97%. Dr. Omollo, do you have additional information on that? I know it's the testing capacity in East and West Africa is pretty limited, and so I think there's a sparsity of data.
Yes, thank you, Jenell, for that. Yes, the resistance is high among studies that have been done, particularly among men who are having sex with men. The resistance has been shown to be high. No clear data among the heterosexual men and women currently that we have in this setup, but I'm speaking about the research that has been done within our research clinic here in Kisumu, and it's high.
Thank you so much, Victor, again, and Jenell. What a really interesting talk. Thank you so much for joining us today and sharing this information. I'm going to now, well, before I invite Jennifer up to speak, I just want to let everyone know that the Choice Agenda is going to be doing a webinar in December focused on pregnant and lactating people and their inclusion in HIV research and HIV research implementation. To Jenell's really important point, they're not included for the most part in most cases, and this has, you know, there's bad impacts from that. So stay tuned. And without further ado, I am going to ask Jenny to come on screen, share her slides, and give us some perspective from the U.S. National Coalition of STD Directors. Thank you.
Good morning. No, thank you. Thank you for the opportunity. It's great to be here. I am here in place of David Harvey, our executive director, who is traveling to USCHA. So it's great to be here. And thank you also to the other panelists. I'm doing a little bit of a different angle here. We're looking at Doxy PrEP for prevention and sort of the policy and program implications therein for health departments as well as sexual health clinics. I do want to acknowledge Dr. Philip Chan, who is always available to bounce ideas off of and has been invaluable to our work, and also Dr. Julie Jimbrowski, who did a wonderful presentation at the STD Prevention Conference on Doxy PEP, and I did borrow and note some references from her as well. So what do we know? Well, we know the major study, as we learned today, is on Doxy PEP and not PrEP, right? So we do have limited data on Doxy PrEP. The current studies support Doxy as PEP, and there was a great paper that was just published. We heard from the researchers today, but Doxy PrEP is an interesting angle, and it's interesting to explore kind of what this might look like as another tool in our toolbox to address STIs. So there's some medication, and again, I'm not a physician, I'm not a provider, but there's some medication considerations, right? So the first one is resistance, of course. Will increased use of Doxy lead to more antimicrobial resistance? And I know that that has been addressed early in the talk, so I'll kind of stay away from that. The side effects, right? I'm the daughter of 2 pharmacists, so this is something I think about a lot. But generally, is a very safe medication, but there are side effects: GI upset, photosensitivity, esophageal irritation. Now, some of that can be overcome by, drinking a lot of fluid when you take it, maybe having something in your stomach before you take it. But could this impact adherence, right? We really need to think about what would this look like in real world settings. And so, what is the messaging to folks in terms of, well, this will subside, or, these may not subside. Like, what does that look like? Who do we focus this intervention on, right? And so we want to stay away from that word risk, as we discussed previously. Is this open to people who've had a bacterial STI in the past year? Is this open to people who are having certain kinds of sex? What does this look like? And how do we establish the most equitable sort of program possible? And so I really want to highlight that we've learned a lot from MPV and sort of the vaccine dissemination guidelines and sort of how that went. And what we learned is restricting eligibility criteria based on sexual behavior could have significant implications, not just for stigma, but, reluctance to disclose sexual behavior. I know that some clinics and some health departments actually changed that criteria and made it more general and more inclusive so that people didn't have to disclose their behavior or just remove that language altogether in order to be considered for MPV vaccine. So we really need to be, think critically about what does this look like, and really this highlights the importance of engaging the community from day one. Right. And so I've managed clinics all my life. I used to manage Detroit Public Health STD and TB clinics. And, something I think that is really important is engaging the community before the program gets started. You have to engage the community in planning the program, right? Not just planning it, implementing it, even evaluating it. I think the community should be included in every step, just to ensure that you're not making decisions for a community that you are not part of. So again, ensuring health equity is of the utmost importance in this intervention as well as any other. And Dr. Dombrowski said something really that just pinged me, and I wrote it down. Proactive offer of Doxy Prep or Doxy PEP was her specific angle, is key for equity and distinguishes a public health approach from a personal care service. Right? Equity has to be at the forefront of anything that we do if it is at a health department or sexual health clinic. So how do we identify candidates, right? There are a lot of different ways. Of course, at sexual health clinics, folks coming in to use services. PrEP clinics, there are a variety of different kinds, of course, and models, community-based PrEP clinics, embedded ones within sexual health clinics or other FQHCs or primary healthcare clinics, those at pharmacies, HIV care clinics, of course. We could utilize partner services in DIS in terms of maybe this might be an option available to individuals. We can look at our electronic health records and try to identify people that way. Or we can even look at FQHCs in primary care settings, especially in medically underserved areas, and trying to understand how do we access or how to expand access to this service and other sexual health services such that they're part of a total wellness visit, right? I'm of the firm belief that sexual health services should not be separate from primary care services. And what does that look like in reality? What does that look like once it's implemented? Something that we think a lot about. I know that sexual health clinics are sort of this gateway for a referral of a lot of other services, food bank services, housing, primary care. Certainly there are a lot of referrals. So how do we integrate Doxy Prep into a no wrong door model? Right? How do we make it as accessible as possible and that there's no wrong door to get the services that people need? How do we let people know about it? That's a good question. And I know this was touched on by the other speakers as well. Will people want to use it? Do they have enough information to make that decision? Will they use it correctly? And again, this is another opportunity to really lean on the community and the individuals sort of on the front lines doing this work, the activist community as well, really understanding what does this look like? What information do we need? How do we develop culturally reflective consumer-facing messaging materials? And what do those look like? You know, to what extent do we explain rationale of like, why, like, well, how does this make sense? What does this look like? How do we talk about potential side effects, right? In a meaningful way? How do we inform individuals of research updates, right? Because this is kind of, we're building the plane again, as we frequently do in the field as we're trying to fly it. So what does that look like? What duty do we have to inform people of the information that we know as soon as we know it? And how do we disseminate that information equitably? STI testing recommendations, right? Just because you're on Doxy Prep, does that mean you still have to get tested? Do you not have to get tested? What does that look like? And being really clear about that messaging. There's also an opportunity for built-in follow-up calls or reminders. This lends itself to maybe a program manager or someone on staff, a dedicated RN, a community navigator who's able to sort of plan this program. And again, in concordance with the community. So how is this planned with the community? So it's not an afterthought, right? So I feel like sexual health clinics and health departments should never create a program and say, hey, community, how are we doing? We'll meet quarterly, let's talk about it. But really engage them from the beginning, from the planning on. As soon as we say, hey, we have the money to do this, we have the capacity to do this, let's engage the community and have these conversations. The importance of staff training from front to back. This is really important, and it's kind of an afterthought sometimes, and it's to no fault of clinics, no fault of their own, but we have to make sure that staff is on the same page in terms of messaging, that what a provider would say about a program, about eligibility, about availability is the same thing that a receptionist would say, right? Or the same information that's on the website, for example, or on social media, and making sure that our messaging adds up. You never want to erode trust by saying, well, the front desk told me blank, right? And that is not, you know, either it was medical information that shouldn't have been shared, you're fine, you don't need to be tested, things like that. And sometimes, I mean, it's out of a good place. You know, people are busy, people are trying to do the best they can. They're trying to, well, if I kind of triage this, then I'm alleviating some of the pressure off my really busy providers or nurses. So it's from a good place. It's really not from a bad place, but we have to make sure that we're on the same page in a clinic from front to back, and making sure that messaging is consistent, especially about something that's so new. All right, so what are our other considerations? Well, you know, we're going to need additional resources, right? Administrative capacity, certainly, updating standing orders, potentially, SOPs, clinical and pharmacy costs, even though it is relatively inexpensive. We're going to need capacity building, right? So providers, staff, and training, it can be a big lift, especially in clinics with limited capacity. Clinics have been through COVID-19, they've been through MPV, a lot of turnover, a lot of trouble retaining staff and inability to pay staff what other sort of maybe non-public health you know, institutions can pay them and to compete with them. So it's really challenging. So it's not like, oh yeah, staff training, like staff, we need staff before we can train them. So really thinking about capacity and, you know, do we have the ability to do this? Buy-in is huge, right? You've got to have an on-site champion. I really want to highlight that in any program, anything that anyone is trying to do, any intervention overall. The importance of an on-site champion makes all the difference in the world. Doesn't necessarily have to be a provider, but you need someone on site who's like, hey, we're back to this. How's this going? Like really excited about it, really wants to see it through. And there's an opportunity there to engage a community champion, right? Like, can we partner a community champion, give them a paid position within the clinic and have them be like the co-pilot to the staff champion? Is there an opportunity there? Optimized EHR, right? So important. I can't tell you the clinics that I go to that are just really great clinics, and you know their EHR, they have a great EHR, but it's not optimized, so they're double entering data into REDCap, right? It's a huge resource suck. And so really making sure that we have an optimized EHR, a data capture system. Can we share orders? Can we share, you know, templates among EHRs? As a sexual health clinic community is an opportunity for that. I previously mentioned this, but maybe dedicated staff, program manager, an RN, really making sure that we're following this program closely because we really need robust evaluation data, especially at this juncture. Again, Doxy is relatively inexpensive, but we don't have consistent information on insurance coverage for Doxy prep and what that looks like. And certainly there could be 340B considerations. Also, how should DIS interact with individuals on Doxy prep, right? So, do people still have to engage in partner services? Are there different considerations? Is there a different workflow for DIS when engaging with someone who's on Doxy prep? What does that look like, right? What do those interviews look like? Is it any different, et cetera? It's important to consider, again, the existing capacity of sexual health clinics. They've been through a lot. They continue to be through a lot, something that we're talking quite a bit about at NCSD, and really trying to think about sustainability and what does it look like, having to respond to crisis after crisis. What does it look like to provide basic levels, right? We did a survey a couple months ago on MPV, and 64% of clinics have had to modify their workflows to respond to MPV, right? And so it's disruption after disruption. And so when are we ever going to be at a place where we can sustain, routine STI testing and treatment services and feel good there, and then be able to take on, something else and something new and something innovative? We really have to think clearly about our capacity. What about testing? So I want to point this out. So again, providers, according to CDC, should continue to screen, test, and treat for bacterial STIs, according to the treatment guidelines. Whether you're using Doxy, PrEP, PEP, or not, right? So that's something we have to be really consistent about and make sure that the messaging is there. Asymptomatic screening is something that has really been decimated in the past few years due to a variety of reasons, capacity issues, COVID again, MPV. So it's really important that we continue to innovate around, non-clinic based self-collect STI testing, for example, and just sort of how do we increase clinic capacity, and maintain access to asymptomatic screening. So what's the bottom line? Well, we need more research on Doxy prep, of course, but it could be great. It could be potentially really useful. Implementing Doxy prep would require significant administrative infrastructure. And again, it's imperative that Doxy prep programs are planned, implemented, and evaluated with input from the community. This should be from day one, right? You don't even think about planning. If you have an idea to have it, engage the community then. That is the juncture at which the community should be engaged. If you do it a second late, you're too late. Sexual health clinics need additional resources. NCSD is certainly fighting for a dedicated federal funding stream for sexual health clinics as well. All right, that's all I have. Thank you so much.
Jennifer, this was a beautiful talk. Thank you. And I know I asked you all to do all your talks so quickly, and you all just rocked it out and got everything in there clearly and beautifully. I would love to have a question from the audience. So if someone would like, first of all, if you could stop sharing your screen, Jenny,
Oh, yeah,
and then that would be great. And then if someone wants to raise their hand, we're going to probably go over a few minutes just to let people know it is recorded. So if you miss the tail end, there'll be some good stuff here. But I want to, I'm really glad you're talking about the capacity of STI clinics. And I would love for you to give a little more flavor to like what the resources are that are needed. And I just want to acknowledge and make that's something that maybe we all know or aren't fully aware of, but the public health system and STI clinics have been grossly underfunded in the United States for the last several decades. And they have been increased, before COVID, they were at wit's end, cutting hours, having lots of challenges throughout the country. And then they're expected to take on COVID, they're expected to take on MPV. We're increasingly looking to STI clinics to deliver PrEP, HIV PrEP, and now Doxy PEP, maybe Doxy PrEP. Everyone's like looking at an STI clinic, says this is a place to be, yet we have not really supported STI clinics in the way we should. So what is the National Coalition looking for in terms of resources to get our STI clinics and public health clinics kind of whole and healthy?
Yeah, thank you for that question. So I think the magic number, and don't quote me on this because the policy team will call me instantly and if I'm wrong, but I think it's $500 million. I think that is the ask in order to sort of establish a funding stream for sexual health clinics just to be sustainable. Really what, so sort of the thinking behind this is that there's a lack of dedicated public health infrastructure. And consequently, anything that pops up is a crisis almost immediately because of that lack of infrastructure. And so if we can really just catch our breath, maybe build up some infrastructure, maybe be able to pay people, wages that are sustainable, right? And so there's just been a tremendous amount of turnover. A lot of positions were like converted over to like the COVID teams early on during the COVID pandemic, and they were not backfilled. So those positions were then, oh, it's under you now. And there was no sort of creation of new positions under sexual health services. And so that has really, really, really tremendously impacted, sexual health clinics and their ability to just do the work that they do. So I think it's twofold. One, continue to build the public health infrastructure of these clinics. Two, I think really letting the community decide sort of the winners, right? Like we can't just continue to fund the clinics that have good marketing or the clinics that, because we need to fund the clinics where people are going and where people feel safe going, and really be able to elevate those clinics to give them the resources that they need to expand their capacity and their services, right? Because if no one's going to your clinic, it doesn't matter how good you are. It doesn't matter how great your advertising is. We need to fund and elevate the places where people are going. There's a lot, there's a great movement toward mobile vans and those kinds of services. Self-collect testing has been really remarkable. I know LA County was utilizing it for people who were quarantined, people who had MPV that were quarantined. So they were sending them kits to their homes to be able to test themselves and send it back. Self-collect kits were also used in Erie County, in Buffalo, New York. They were used, they were handed out to people who were in line for MPV vaccine. So really, I mean, clinics are very good at innovating, right? That's kind of what we do. That's what we've been really good at, and we've had to learn to sort of be resilient and get good at innovating. So really engaging these smaller clinics, right, who are doing the work on the front lines and saying, what do you need? If we get this money, how should we spend it? What should that look like? How can NCSD engage these smaller clinics, and like, what should an RFP look like? So say we get the funding, how do we shape what this RFP looks like so that everyone is equitably able to apply to this funding?
Wow, beautifully said. So much to unpack there. I'm gonna take the final question from Rodney, who's one of our fellow presenters today. But I want to give a plug to voting, to all of our US friends here. When we're thinking about public health funding and STI clinic funding, it all comes down to who you put in Congress and who supports this. And the reason why we have not had good public health funding for decades is because there hasn't been support in Congress. And that means we're not doing our part in community pushing our elected officials to do the right thing. We want to have all of these services. We need to pay for them. And so I would urge everyone to talk to their elected officials. We're in a voting season now. It's always voting season in the United States, but we have midterms coming up, and then more, ever-ending elections. So please, please, please use your power as a community member. Don't sit back and whine and complain, or you can want to complain and then get on the horn and read someone out for their support on for public health and STI clinics. But the final question, which I think is really great, it's from Rodney, and he wants to know, what are the barriers to self-testing to capture asymptomatic STIs? It seems if we could do more self-testing, we could potentially have much better sexual health across our population.
Thank you so much for that question. I think it's really important. Some of the barriers are return rates, believe it or not. They kind of hover among programs between 25 and 30%. And so there are two kind of models for this. One is sort of like a bulk workflow where a clinic, a program has a bulk set of kits. They can activate them and hand them out. So in the example of, handing kits out in the MPV line, for example. The other sort of model for this is, having a social media ad, having a website where I, as a person, an individual, can click and say, hey, do I want a free kit? Sure. And I'll put my address in and and then I get a kit sent to me, right? And like, well, what does that look like? How then are we able to ping that? Are there automatic reminders built into the portal? What kind of messaging or education would be important in sort of helping move the needle there? I think if we can sort of figure out, and I think there's some behavioral elements there too, and kind of like what that looks like. And it's like, oh, well, I'm not symptomatic. If I were symptomatic, I would go to the doctor. So I don't really need to be tested right now, right? We did a pilot program at NCSD. We had close to a 26% positivity rate in the completely asymptomatic population, right? And so that's jarring to me, because that means that there's a lot of asymptomatic disease in the community that people don't know about. And so how do we tailor messaging in a way that doesn't elevate risk, but says, you don't have to be symptomatic in order to have an STD, right? And so that's something that we really, I'd love to hear your thoughts on, actually, and really think, strategically about how we message that, because I think that there's an opportunity there in messaging that would say, hey, you're right. How do we elevate the importance of asymptomatic screening when I'm pretty comfortable, right? Like if I need to get tested, I would know where, but I don't need to right now, right? I'll use it when I need to. So like, how do we kind of change that? And like, maybe, create an opportunity to have a conversation or engage, particularly when there's no provider involved, where I just ordered a kit because I could, and the health department advertised it. So I have a kit for myself. So I'm just going to keep it around until I need it, right? So how do we kind of change that conversation a little bit?
Yeah, such great points. And I think we have like maybe lessons from prep programming where we have STI screening built in, and it's not about symptomatic screening. You just get screened every 3 months, boom, and it just becomes normal. It's part of the routine. I'm not a car owner, but you take your car and get the air put in the tires, and someone kicks the tires, and someone sticks a dipstick in the thing, and right, you do that on a regular basis to keep your car. You don't wait till your car is falling apart. You take care of your car as you're going. And so that's sort of the same thing. But we clearly have a lot more to do and your point about such high levels of asymptomatic infections, if we can get people thinking about this is just sort of part of my natural health care. I brush my teeth. I don't wait till I have a cavity to brush my teeth. I brush my teeth every day to avoid cavities. Maybe there's a way we can think about making this a habit, and then the more we're all doing this, it could also help with stigma reduction,
Absolutely. Well said.
So I want to thank Jennifer. I want to thank all of our other really great speakers today, Connie, Rodney, Victor, Jenell. Give them, if you're a lot of you are still here, so give them some love in the chat, please. Really, really wonderful talks, learned a lot. I'm really grateful for all of your time and expertise. Everyone can expect to get a follow-up email from me, probably Monday, maybe later today, with a link to the website where you'll have the recording, the slides, and a resource document with some of the links that we shared. Please look forward to our next webinar in November on PEP, HIV PEP. And then, as I mentioned, in December, I'm really excited. We're going to be doing a webinar with pregnant and lactating people, talking about pregnant and lactating people inclusion in HIV research, and so important. And by the way, we're also doing a webinar in December. December gets 2, talking about transgender inclusion in HIV research. So it's all about inclusion in December. We're going to end the year off right. Look forward to seeing you all there. Stay tuned in your email boxes. And with that said, I'm going to bid everyone a really wonderful day, evening. Go take care of yourselves, enjoy, and I hope your weekends are wonderful. Thank you so much.
Thank you. Thank you.